Good evening, everyone. I would like to welcome Murukan Babu, sir. He's very active in all our academic programs. I myself have attended a couple of cadaveric courses under him. We are privileged to have him here for our ankle OSCE session. Over to you, sir.
Thank you, Balu, for the nice words. So I have prepared around 10 cases, all slide based. Most of them are X-rays because the ankle, most of the cases, most of them are related to the ankle fractures. And I try to include some clinical scenarios and also some cold cases. And we will discuss one by one. So the first case, Balu, you may have the first next slide, please. So this is an X-ray of the ankle, the AP view only. So these are the questions to be answered. So the first one is diagnosis and what is the classification of this fracture, and what about the medial side injury. So can anyone answer this question? Yes, Balu, you can coordinate. I don't know most of the I know only few people, and you can call somebody so that so we can go on with discussion.
Yes,
Shinas,
sir. Yeah.
So what is the diagnosis in this condition?
Lateral malleolus fracture with deltoid ligament.
Yes, very good. So it's a lateral malleolar fracture. You can see the medial side is very well. The opening of the medial side is there. So can you comment on the position of the talus? Is there anything on the position of the talus?
Talar is subluxated, sir, due to deltoid ligament injury.
Okay. So there is some translation of the talus. So pushing the lateral malleolus towards the lateral side with the widening of the medial joint space. So what could be the classification? So in which heading this fracture comes? Can you classify this fracture?
Weber classification and Log-Hansen classification.
Very good. So in Weber, so the first one, Weber classification. What will be the Weber classification?
Type B, sir. Type B.
Type
B at the level of Syndesmotic.
Yes, at the level of Syndesmotic. Okay, so Weber classification is basically the level of the fracture of the fibula. It is infrasyndesmotic at the level of syndesmotic and suprasyndesmotic, A, B, and C. Okay. So coming to the Log-Hansen classification, so in which group this comes?
Pronation external rotation injury.
Pronation external rotation injury.
Supination external.
So yeah, is it supination or pronation?
Supination external rotation.
Yeah, supination external rotation. So by looking at the AP view alone, so how can you say that it is supination external rotation rather than a pronation external rotation injury?
Sir, the
fibular fracture. Okay.
Fibular fracture is oblique at the level of syndesmosis.
Yes.
Medial inferior to lateral superior. The fracture line goes medial inferior to lateral superior. Fibular fracture.
So you have only AP view here.
From lateral.
Okay. By looking at the AP view alone, pronation external rotation, usually the fibular fracture is suprasyndesmotic.
Yes.
Isn't it?
Yes.
Yes. Okay. So in supination, this could be a supination external rotation injury because the fibula is an oblique fracture, probably from the inferior to superior level, and there is widening of the medial joint space. Can you say the different stages of supination external rotation injury? So there are different stages described in supination external rotation injury. So what is the thing that first happens? So there are different books giving different things. Some books say that it is the deltoid ligament. Actually, it is actually stressed. But classical teaching, can you say what are the different stages? So initially it is the ligament that is torn.
Anterior talofibular ligament, starting from anterior tibiofibular ligament.
Yes, anterior tibiofibular ligament.
Then fracture comes to the second to the lateral malleolus. Oblique fracture on the lateral malleolus. Then goes posteriorly, involving the posterior malleolus. Then posteriorly start with the posterior tibiofibular ligament, then to the posterior malleolus, and finally reaching to the deltoid ligament for avulsion of the medial malleolus.
Oh, it's not actually what you said is perfectly right. Probably the last thing. So it is basically rotation of the talus. So finally the talus rotates. It hitches on the posterior malleolus, produces posterior malleolar fracture, and then it rotates again and producing a medial malleolar fracture. Rather than avulsion of is due to the hit of the talus on the medial malleolus. So these are the different stages of supination external rotation injury. So coming to the third part, so sometimes you may get some clinical evidence of medial side injury and the X-ray may not show any obvious medial joint space widening. In such scenario, you may have to take a stress X-ray. So what is the force, the stress that should be given to get a stress X-ray in suspected medial ligament or the deltoid ligament injury?
External rotation of the foot. AP.
Yes, exactly. Just like the supination external rotation injury, you give a supination external rotation force and take a check X-ray.
AP.
So that is this X-ray. The stress force that you should give is the supination external rotation force. Then coming to the management. So how will you manage this case?
Fix the lateral malleolus and repair the deltoid ligament with suture angle.
Okay. So is there a conservative role? Is a conservative treatment? Is there a role for conservative treatment here? In deltoid ligament with lateral malleolar fractures. Of course, what you said is right. Surgically, this should be treated surgically, but is there a role for conservative treatment? Suppose the patient has some comorbidity or the patient is not willing for surgery, or the patient is not able to withstand that surgery. In that case, what will you do? So always you should know how to treat it. Most of the fractures, you should know how to treat it conservatively without putting knife. So that is the idea of knowing the force produce this fracture. That's why we know also this classification and all comes. The supination external rotation injury produce this type of fracture. So you reduce the fracture in the opposite direction and take a check X-ray. So if you get a very good clear normal space on the medial side and the fibula is well reduced, you may or you can treat conservatively, but only problem is you should have a thorough vigil on the patient X-ray. You should serially take X-rays on every week and see whether there is reduction or loss of reduction of the fracture. So there is a role for conservative treatment, but most of the time this conservative treatment fails because of loss of reduction. But you should know how to reduce this fracture. Okay. So as you said, if you are going to surgically treat the fracture, you need to reduce the fibula and fix the fibula. So would you go for a deltoid ligament repair? Srinaz, can you hear me?
Yes, sir. Yes, sir.
Would you go for side only, or will you go for a deltoid ligament repair?
We do.
So in all cases, you need to do deltoid ligament repair, or what is the recommendation given in textbooks?
If there is medial clear space more than 4 millimeter, then and the Then we have to repair deltoid ligament.
Okay. So, so after reduction of the lateral malleolus, if there is a clear joint space of more than 3 to 4 millimeters, you need to intervene on the medial side.
Yes, sir.
So, what you expect on the medial side? Why there is even though you have reduced the fibula correctly, there is widening of the medial joint space still persisting. So, what could be the reason for increased joint space on the medial side?
Subluxation of thallus bone. Subluxation.
No, if you corrected the subluxation is there. That is why there is medial joint space, increased medial joint space. So, what could be the reason for this increased space? Is there something, there's some radiolucent tissue there?
So the torn deltoid ligament can be there in between the talus and the medial malleolus.
Yes. Yeah. That could be the reason for increased joint space. So there are.
Murugan sir had a technical issue. He will join soon. Babu sir, you want to add something?
Yeah, but Murugan is gone.
Yes, sir. He just now got disconnected, sir. He'll join soon.
First, I'd like to go back to the classification. Is it a pure supination external rotation, or is there an element of pronation abduction here? Not pronation external rotation. Most of the time when ankle fractures we find such cases, of course, is a low fibular fracture, but there could be an element of pronation, abduction here. If it is a pure supination external rotation, you get a pull off of the lateral malleolus, and then the sequence of events is when the talus comes posterior malleolus, then comes to medial malleolus, and oblique fracture of the medial malleolus. Can you hear me? Am I clear?
Sir. Yes, sir.
Yes, sir.
Yeah, so I have a little skeptical about the classification. It's pure supination external rotation, or there is an element of pronation of the abduction here.
Sir, can I comment on it, sir?
Yeah.
Babu, just sir.
Yeah.
So one thing I'd like to tell all the postgraduates, whenever you have, sir is such an expert, and you have some confusion in whether to diagnose it as a supination external rotation or a pronation external rotation or abduction. So two things I would like to tell you is look at the fracture line, where it starts from. So Srinivas, where is the fracture line starts in this stage, fibula? Is it close to the joint or higher up in the joint?
Start close to the joint, sir.
So whenever you have such a pronation injury, it gives you a stress, and normally the fibula breaks higher up in the. It normally will break. The break starts in the joint above the joint line. Okay, so that is one of the. I won't say it is always there, but most of the time, whenever you have a pronation injury, the fibula fracture is what level, Srinivas?
It will be away from the
Syndesmotic.
Yeah, it will be higher up. And also, whenever you have an oblique injury of the fibula, if you trace the lateral view, the fracture starts from the anterior to posterior or posterior to anterior. Srinivas.
Sir, in supination, it start anterior to posterior.
Exactly. So these two things, if you look carefully, then you can give an opinion whether it is pronation, external rotation, or supination external rotation. Is it clear, Srinivas? So what are the 2 points which we have considered now? One is the level of.
In the AP view, we have to look whether the fracture starts near the joint or away from the joint.
Exactly. Okay.
And lateral view, we look the direction of the fracture, whether going below, up, or from superior to inferior.
Yeah. So anteriorly, whether the fracture is anteriorly, whether it is higher up or lower. So in a supination external rotation, the anteriorly it will be lower or higher.
It starts lower. Anterior lower.
Exactly. Is it clear for everyone? I wish I had a lateral view to show you that. Then it will have a better understanding about this. And what Dr. Murugan was saying is that whenever you have a persisting clear space in the medial side, that means something is there. So most of the time when you open up, you find the infolding of the deltoid. But if it is a very severe injury, you can even, what are the other structures you can expect in us on the medial side other than the deltoid?
Balu, I could rejoin.
Yes, sir.
Yeah. Back to you. Back to you. Let me just intervene
just
for
please
a second.
continue. Please continue. Just
No.
please continue.
No. One more point. So all the medial structures, like what are the medial structures you can expect in us in close to the medial malleolus? Yeah. So sometimes this can also subluxate in. That's so whenever you are not able to reduce it fully, always it's good to open up, visualize whether it is an entrapped deltoid. Sometimes it can be a tendon, but as Dr. Murugan has said, it is a radiolucent soft tissue. That's what you must look for. Back to you, Dr. Murugan.
Thank you. Sorry, it was heavy rain here, so the generator is switching on and off. So in between the Wi-Fi goes. That is the issue. Okay. So sequence of repair. So did we discuss that?
Yes, sir.
No. Go ahead.
No. So what is the? So you have opened the lateral side and you reduced it, but the medial space is still not reduced. In that case, you need to open the medial side. Then after that.
Yes, anybody can help Shinas. Feel free to discuss. Abin, Afsal.
Repair the deltoid ligament.
Yeah, repair the deltoid. So, but the classically you should do is you open the medial side, so remove especially the deep part of the deltoid ligament from in between the tibia and the talus, and take sutures through the deltoid ligament, and you can take osteoperiosteel sutures through the talus and reduce it, but don't tie it. Then come back to the lateral side, fix the fibula completely, and then you tie the sutures on the medial side. So that is the order, especially that is given in the Campbell. So you try to reduce the fibula first. Don't apply the plate and complete the fibula, because the medial side is still not completely reduced. So you come to the medial side, reduce take out the deltoid ligament, take sutures, go back to the lateral side, fix the fibula, and then come back to the medial side and tighten the deltoid ligament. Is it clear?
Yes, sir. Yes.
Okay. We'll go to the next.
Hello, sir. I have a doubt.
Yes, please.
Sir, is there any role for syndesmotic screw in this case?
So this is a type B fracture. Type B. So the syndesmotics may not be involved. So in supination external rotation injury, you can get syndesmotic injury, but this anterior talar fibular ligament is not completely gone. So the classical thing, so the thing is, if the syndesmotic injury is more than 3 centimeters above the tibial plafond, then only you need to fix the syndesmotic area. Otherwise, by fixing the lateral malleus alone, you will the syndesmotic injury can be tackled. No need to put any syndesmotic screws in this case.
Okay. Thank you.
So next case. So this is the clinical sign. So what are the tests or the signs are shown here, and what is the clinical significance? So relatively simple question.
Yes, Dr. Kannan.
So this will be Thompson's test to test for the integrity of the tendon Achilles.
Very good. Okay. So is there any other sign? The second picture.
So there will be
mantle sign.
Mantle sign. So what is the difference between these two? So you can see in the picture itself. The first one in Thompson's test, actually you're squeezing the calf muscles.
Yes.
So otherwise you're keeping the knee, the patient in the prone position and the knee in the flex position. So the gravity. So because of the discontinuity of the tendon Achilles, due to gravity, the foot falls dorsiflex. Gravity helps the dorsiflexion. So the involved portion There will not be much of equinus, so the foot will be in dorsiflex position. So that is the difference. So when will you get a false negative test? False negative.
Chronic tear.
Yeah, chronic tear. Chronic tear with, so the fragments, pardon?
Fibrosis in between.
Yes, chronic tear with fibrosis in between, there will be this continuity, and you might get a false negative test. The management is, of course, so you have conservative treatment, but most of the time you go for an end-to-end repair after opening up. If there is any scar tissue, we remove the scar tissues and try for an end-to-end repair. And anyone knows what is this Kager's triangle?
It is a radiolucent area which represents the Kager factor.
Yes, yes. So what will happen to this Kager's triangle in case of a suspected or a tendon Achilles injury?
It will get
The posterior border will be absent.
Yes, very good. So, Balu, can you go for the next slide? Yeah, so here, no, so you can see this a triangular area just in front of the tendon Achilles. So that is marked also, that is under Kager's triangle. So in case of a rupture of the tendon Achilles, the posterior border of the triangle will be lost, and you won't get a clear Kager's triangle in case of this suspected or a tendon Achilles injury. Okay, any doubt? So, or else we can go to the next case.
Yes, sir.
So, this patient with a right angle pain and swelling for 3 months. Someone can name the condition and what is the most common location of the condition, and what are the causes, then staging system and treatment.
Yes, Dr. Razim, can you take this? Dr. Razim? Yes, Dr. Manoj, yes. Can you repeat it, please?
Osteochondritis dissecans of the talus.
Yes, very good. Yeah, it's an osteochondral lesion of the talus. So, what is the most common location?
Medial dome of the talus.
Supromedial dome.
The medial side. Yes, medial side. Medial side of the talus is the most common location. And what are the causes?
Repeated injuries, microtraumas, degenerative conditions.
Okay, okay. So these are the different causes of this. So can you say something about the staging system?
Burnt and Hardy.
Yes, it is a Burnt and Hardy classification. So there are different stages given. So one is the type 1, stage 1. There is only a compression fracture of the subchondral bone. Then in stage 2 there is a partial. Then but without displacement. And stage 4 is complete. The stage is displayed by Burnt and Hardy. Can you go to the next slide? So that is given there. So can somebody read this? So purely a theory question. It's an osteochondral lesion of the talar dome. Most common location is medial central, then posteromedial and lateral central. It's bilateral in 10% of cases. So these are the different causes described, and the staging system is Burnt and Hardy. Next slide, Balu, please. And these are the staging system. And then coming to the treatment part. So in initial stages, you can go for conservative treatment like non-operative treatment, and then stay in completely detached fragments and displaced things. You can either try primary fixation, then excision and curettage, then osteochondral grafting, autografting, and AST. These are the different treatments described for this condition. Next slide. Then, So I don't have any personal experience of this as this chondrocyte implantation or any osteochondral. That's all. I have debraided one case arthroscopically on the. That is the only case I have seen. So, any Babu sir, any experience with this type of cases?
Yeah, very, very rare, like you said, Dr. Babu. I saw one case like this, maybe that was stage 3, and they offered surgical treatment, but they opted for conservative treatment. But other than that, no, very, very, very few cases we see in the OP.
Okay. So that is just a spot only. So you should know such a case. So if in the exam, if it is asked, you should be able to answer those questions.
Yeah, this osteochondral autographs and ACI and the Arthrex have come out with new treatment method for this, where they fill up this thing with cartilage parts. I mean, ground parts of the cartilage and filling it up, and then you can do it arthroscopically and semi-open also. So I have no experience.
Okay. Any questions? Balu?
Yes, sir.
Postgraduates, they have any doubts about this?
Any doubts, or shall we go to the next?
Next.
Okay.
So, identification and what is it? Any?
Is Dr. Srijit? Can you take this question? Or any volunteers?
Avian neck of talus.
Yes, Dr. Manoj.
Avian neck of talus. Avascular necrosis of talus. Talar neck.
So the avian usually you need to see in an AP view. So we'll come to that in the next slides. So this is the MRI and the X-rays given only lateral views, and they concentrate on the posterior aspect of the angle. Can you see something there?
Yes. Trigonum.
Yes, very good. It's called os trigonum. So what is the etiology? So in the anatomy, the talus has got the head part portion, the neck and the body has got medial process, the posterior process, and the lateral process. So here the posterior process is not getting united during development of the body of the talus, producing a separate bony piece called the os trigonum. So this is due to failure to fuse the body of the talus. And what is the clinical presentation? Is there any problem for the patient with this condition?
Impingement, sir. Limited dorsiflexion.
Yes. And it causes a posterior impingement, especially on which movement it produces posterior impingement.
Plantar flexion.
Yeah. So because on plantar flexion, this goes and touches the posterior part of the tibia, producing a posterior impingement syndrome. So is there any differential diagnosis for this condition?
Posterior process fractures.
Yes, exactly. Posterior process fracture, you get a setable. So how will you distinguish between this osteochondral and posterior process talar fracture?
Condor of the fragment.
Yes, usually this condition is a chronic condition to us there, and you get a clear round, almost without any irregularity of the surface. You get a clear nodule, radiopaque shadow in osteochondral, but in posterior process talus, usually the irregular margins, and usually it fits into the body of the talus just like a jigsaw puzzle. So that's how you differentiate between osteochondral and the fracture. And treatment is usually activity modification and NSAIDs, the conservative treatment. And sometimes if it's very painful, you can go for arthroscopic removal of the fragment. Okay, so that is the treatment part. Can we go to the next slide? So what are these arrows indicate? Next, who is going to take this?
Dr. Shankar.
Osteonecrosis.
Subchondral sclerosis.
Hawkins sign.
Hawkins sign.
Subchondral osteopenia. Subchondral osteopenia.
Subchondral osteopenia.
Yes, it is subchondral osteopenia. Yes, subchondral bone density is reduced. It's not sclerosis, it's subchondral osteopenia. So what is that condition called? What is the sign called?
Hawkins sign.
Hawkins.
So when will you get this Hawkins sign? Is immediately after the fracture?
Revascularization after about 6 to 8 weeks.
Yeah, usually it happens 6 to 8 weeks after the injury. So what does this indicate? Is it good?
Good sign. Good prognosis.
Yeah, it's a good sign. It shows vascularity of the
Intact vascularity.
after surgery. So you can see a screw there. So the revascularization of the body of, so that you need to know the blood supply of the body of the talus and anatomy of the talus is a bone having about 2/3 of the bone is covered by cartilage, and only few places you have periosteum so that the blood vessel go into the bone. So which are the areas having this periosteal attachment? So most of the areas covered with the cartilage and the ankle joint, ankle mortise, and subtalar joint, talonavicular joint, everywhere. So which are the areas you get the periosteal attachment so that the blood vessels can go into the talus?
Sinus.
Deltoid.
So it is in the talus and also some part of the posterior process. So these are the areas. So Hawkins sign is described in which type of talar fractures?
Talar neck.
Is it head fractures, neck fractures, or body fractures?
Neck fracture.
Good. So can you classify the talar neck fractures? There are different types of talar neck fractures.
Four types.
Yeah, 4 types. Who classified this talar neck fractures?
Hawkins.
Hawkins. Good.
Yes.
So the initial Hawkins classification, there are only 3 types, and it was modified by another person with a modified Hawkins canal classification. You got 4. Type 1.
Canal.
So type is an undisplaced fracture. Always can say type 1 is an undisplaced fracture. And type 2?
With the subtalar dislocation.
Yes. So type 2 is a displaced fracture with the subtalar joint. Then type 3.
Type 3 is with subtalar and tibiotalar dislocation.
No, talonavicular.
Type 3 is actually, yes, so type 3 is type 2 with ankle subluxation. In type 4, you have complete dislocation, the ankle subluxation. So, depending on the type of the fracture, the avascular necrosis chance increases. So, what are the complications of talar fractures? Complications.
Avian pneumonia.
Yes.
Post-traumatic osteoarthritis.
Yes, post-traumatic osteoarthritis. So ankle arthritis and subtalar arthritis. Okay, so these are the complications, major complications, that's vascular necrosis, ankle arthritis, subtalar arthritis, and also talonavicular arthritis. Okay, so the management of complications depends on the amount of vascular necrosis. You don't have much to treat for vascular necrosis, but for ankle arthritis, initially conservative treatment, followed by ankle. In ankle arthrodesis, what is the usual treatment in advanced ankle arthrodesis? What will you do? Ankle arthritis, advanced stage treatment.
Arthrodesis.
Yeah, very good. So can you go for an ankle, just like in knee arthritis, you do a knee arthroplasty, hip arthritis, you do hip arthroplasty. Can you do ankle arthroplasty in these type of cases? So you can do ankle arthroplasty, but the results are bad because long-term results are bad because you can fix the implant on the tibial side very well, but on the talar side, the bone purchase is very bad, and the chance of failure is high. So most of the cases we do very well after arthrodesis. So these cases, the treatment of choice is gold standard treatment is ankle arthrodesis. Next case. Yeah, another trauma. So what is the diagnosis and classification and management?
Dr. Varsha, can you take it? Yeah. Dr. Varsha, are you there? Or Dr. Rajendra?
Pronation.
Okay, Dr. Kannan.
Sir, this could be pronation abduction injury with the transverse fracture of the medial malleolus and comminuted fracture of the lateral malleolus and the dislocation of the tibia with avulsion fracture of the posterior malleolus.
So you said pronation abduction injury. Abduction is only one plane. There is no rotation element. In that case, will you get a posterior malleolar fracture?
So the posterior mal would be because of the dislocation, avulsion of the PTFL.
Yeah. So then the classification changes. It's not pronation abduction.
Oh, okay.
Pronation external rotation, sir.
Pronation.
Yeah. It's
supination external.
Supination external rotation.
Yeah, is supination external rotation or pronation external rotation?
So looking at the medial malleolus, it would be pronation external rotation.
Why?
Supination.
So the transverse fracture occurs in pronation external rotation of medial malleolus.
In both.
Yes. But you can get even the transverse fractures and supination external rotation also. Supination external. So by looking at the fibular fracture, so this is more for a supination external rotation. Supination external rotation injury. Okay, so you should be able to classify these fractures after you. So every time you see an ankle fracture, so most of the time we all say the bimalleolar fracture or a trimalleolar fracture. But always you think about when you see an X-ray, you think about and you critically analyze the medial side, lateral side, and the posterior side, and then you arrive at a diagnosis and cross-check whether it is correct or not. By looking at 10 X-rays, probably you may be able to answer all the questions. The next 10 angle fractures, you don't say it is bimalleolar or trimalleolar in your unit. You classify the fracture according to Lohan's classification, and then that is important. So for that, and the lateral malleolus, the fracture fixation. So will you fix all the posterior malleolus, or so is there any criteria for posterior malleolus fracture fixation?
So if the posterior malleolus fracture involves more than 25% of the articular of the tibia, then we'll have to fix it.
Yes. Okay. Then that is the size. So depending on the size, if it is around 30%, you should fix the fracture. Otherwise, you can leave the fracture. That is what literature says. And depending on the displacement, so depending on the distance, about 2 or 3 millimeters, if it is displaced proximally, you may have to fix. And also the stability. So even if it is not, the ankle joint is not stable, if it is going posteriorly, even after reduction, in that case also you need to fix. So there are 3 criteria depending on the size. If it is around 25 to 30%, displacement about 2 to 3 millimeters, and if it is contributing to ankle instability after reduction, you should fix the posterior malleolus.
Yes.
Okay, is it clear?
Yes.
Yes, sir.
Okay.
Babu,
Okay, any question?
Babu, can I interrupt?
Yes, sir.
Can I just make a comment?
Sure, sir. Please.
Yeah, to the postgraduates, I just would like to add that 40 to 75% of ankle injuries fall into supination, external rotation, and pronation, abduction, pronation, external rotation. It's only about 20%. And if you look at the X-ray, in most of the time, this is a supination, external rotation injury. But if it's a pronation, external rotation injury, the fibula fracture is always higher. And there are high chances of a medial collateral ligament injury, superficial and deep. I just wanted to make that comment. What is your take, Dr. Babu?
Yes, sir, exactly. So by looking at the fibular fracture alone, so this medial malleolar fractures, it is given that if it is a transverse fracture, it's mostly seen in pronation, external rotation, and pronation abduction. But transverse fracture can occur in supination, external rotation injury also. So you cannot say whether it is a supination, external rotation or a pronation, external rotation by looking at the medial side. By looking at the lateral side, if it is suprasyndesmotic, most of the time it is a pronation, external rotation injury. But if it is at the level of syndesmosis, most of the time it's supination, external rotation. And as sir said, most of the majority of cases are supination, external rotation injuries. So this is okay. So next case. So this is a test. What is the test demonstrated here? What is the clinical importance?
Yes, someone answered. What was it?
Silver skull test.
Yes, it is silver skull test. How is it done? So it is given in the pictures. So can you elaborate by looking at the pictures how it is being done?
First ankle flexion we have to done in extension of the knee joint, and then flex the knee joint, and then if it is further we can dorsiflex, then the tightness will be there in medial gastrocnemius.
Yeah, good. So do the ankle dorsiflexion in extension and see the amount of dorsiflexion coming, and then repeat the same with the knee flexion. If the ankle dorsiflexion increases, there is the gastrocnemius contracture. That is the test to distinguish whether the contracture is due to gastrocnemius or due to soleus alone. Yeah, that is the clinical importance. Okay, so anything more to add, Babu sir? Balu? Okay, then we move on to the next slide so that we can finish 1 or 2 cases more. Another case that we just discussed. So what is the diagnosis? Then what is classification? So this is actually taken from AO, this slide. So, can someone read this X-ray?
Yes, Dr. Andrew Jose. Or Ganesh, Dr. Ganesh?
Sir, this is a plain radiogram
Yes.
of angle joint of a skeletally matured.
Yes, very good.
Showing angle joint and mid to distal 1/3 of leg with transsyndesmotic injury.
Yes.
With proximal 1/3 fibula fracture.
Very good, very good. So there is a proximal. When you look, so if you look at the lateral view, especially, probably you may not be able to see the fibular fracture in the AP view, but if you carefully, probably it may not be visible in your mobile screen, but you can see in the proximal fibular fracture. But it is very well. You can clearly see it in the lateral view. And on the third picture in the AP view, it's a closer look. So it's so what is that view called?
Mortis view.
Mortis view. Okay. So how to position the ankle for mortis view?
15-degree Indian rotated with dorsiflexion.
Is it internal rotation alone or a dorsiflexion required?
Dorsiflexion with 15 degrees of internal rotation.
Internal rotation. Okay. So then you can be able to see the ankle clearly. Okay. So how will you evaluate an ankle mortis?
Babu, just a comment.
In case of a suspected syndesmotic injury. Hello? Yes, sir? Yes, sir,
just
please.
Comment on the reading of the X-rays to the postgraduates. There is a way to go. Can I go ahead? There is a way to go.
Sure, sir. Please.
Yeah, there is about reading any X-rays for that matter to the postgraduates only. Yeah, there is a way to go about it. So if you look at both AP and lateral views, if you say A, B, C, you look at the alignment. A is for alignment, B is for bone density, and C is for cartilage space. So if you go in that order, you will not miss any findings. Just to make a comment on that. That's all. Just to read an X-ray. Whenever you read an X-ray, you take these 3 things, you will never miss anything. And all the different views also. Yeah.
Okay. So this is for teaching purpose. The next slide. So Balu, can you go to the next slide? So this is the ankle, the mortis view. So probably, so it is given that the tibio-fibular overlap. So that is given in the red line. So if it is less than 10 millimeter, it's abnormal, implies a syndesmotic injury. And clear space is given in green color. If it is more than 5 millimeter, it's abnormal, and that also implies a syndesmotic injury. And the talar tilt. These are the 3 things that you should look in an ankle mortis view. The talar tilt is a difference in width of the medial and the lateral aspect of the joint space of more than 2 millimeter, is indicating a medial or a lateral disruption. So the tibiofibular overlap and tibiofibular clear space. The overlap, it should be less than 10 millimeter, and if the clear space more than 5 millimeter to diagnose a syndesmotic injury. Okay, is it clear?
Yes, sir.
Yes, sir.
Okay. Yes. So can you go back to the slide? Go back. Okay. Then syndesmotic injuries. So clinically, so if the ankle mortis, so you have seen the X-ray, but how will you find out if the X-ray doesn't show any syndesmotic injury, and perioperatively, how will you find out whether there is any syndesmotic injury, especially in isolated lateral malleolar fractures?
Cotton test.
Yeah. How do you do that?
First, we fix the stabilize the joint by keep our hand over the ankle joint or the lower end of tibia, and then using a Alice or
okay. Yeah, the tibia should be stabilized.
Pull the fibula.
Then
then we will pull the fibula.
Okay.
If it is moving
Using
more
a towel clip or some device. Moving,
yes,
so what
it's
you
unstable,
need
so
to
we have to
quantify
fix.
how much movement is acceptable and how much is unacceptable, indicating
More
a
than
syndesmotic
10,
injury.
more than 10 mm.
No, not 10 mm, around 3 to 4 millimeters. So it's less than 5 millimeters, not 10. 10 is huge. So if it is less than around 3 to 4 millimeters, you should suspect a syndesmotic injury. In that case, you need to fix the syndesmosis. And so using the fixing the syndesmotic, you can use either a 3.5 screw or a 4.5 screw. So is there any advantage over using 3.5 or 4.5?
No.
No, both 3.5 and 4.5 is good, giving equal results. And regarding the number of screws, so how many screws you need to put? Is it 1 or 2?
No consensus.
Yes?
Four cortex must be.
No.
At least
regarding the number of screws, not the cortices, number of screws. How many screws you need to put to stabilize the syndesmosis? Is it 1 screw is enough?
One screw is enough.
If one screw can stabilize, it will be enough.
Yeah, but it's given in the Campbell that putting 2 screws gives mechanically more stability than putting 1 screw. So, but most of the time, so we all put only 1 screw, and but if you put 2 screws, it gives more stability. That's what literature says. And regarding the cords, as you said, how many cortices should be? How many cortices purchase is needed in syndesmotic screws?
At least 3. At least 3.
At least 3. So is it? So that also is a controversy. So if you give 3 cortices purchase, you can, without removing the screw, you can make the patient walk. And 4 cortex purchase is good for the stability, because 3 cortices sometimes you may get a disruption of the syndesmosis when the patient is allowed to wait there. So 4 cortices is ideally good, but only problem is if you don't remove the screw before weight bearing, the screw may break. That is the only issue. But breaking the screw in 4 cortices is not a big issue, because you can remove, if needed, you can remove the screw from both sides, because you have purchase on both the sides. So 4 cortices purchase is good, and 2 screws, that is ideal. Okay. Any doubts? Anything?
Shall we go to the next one, sir?
Is it 9 o'clock? Can we continue or shall we stop?
Yes, sir. You can continue.
Finish.
Okay, sir. I think we can quickly go through this.
Okay, so we'll discuss 2 more cases. Okay, 2 more cases. Okay, 2 more cases. Okay. Yeah, the next case. So what is the diagnosis and what is the common age group and management?
Yes, someone can quickly chip in with the answer.
Tillog's fracture.
So what is that? Tillog's fracture?
Triplane fracture of the distal tibia.
Yeah, good. It's a triplane fracture. So it is equivalent to. So you can see that there are different arrows there. So you can see that the physeal area, there is a fracture on the right hand side, which is on the AP view. The median malleolus fracture you can see in the physeal area. So it's a type 4 type 4 like injury. So what is the common age group? So it is usually in the second decade, adolescent age, and around 13 to 15 years for boys and girls. And the treatment is usually close reduction, and if it is stable, it is okay. Otherwise, you can put close reduction and smooth fixation with K-wise.
Okay, sir.
Okay. So get the last case. So here a twisted ankle years back with chronic ankle pain. So can somebody read this X-ray? And next slide, Adalu, please. Read the X-ray and MRI. So what is the clinical presentation? What is the diagnosis? And the treatment. So there is history of trauma some years back.
Yes, Dr. Ragesh.
This is an plain X-ray, ankle view, showing ankle joint and subtalar joint, distal tibia, talus, and calcaneum. And there is decreased density on the head of talus.
So the head of talus, the lateral view usually there will be overlapping of the fibula. So in looking at the talar bone quality, always better you rely on an AP view rather than a lateral view. This is because you're overlapping with the lower end of fibula.
Okay.
So can you see something on the anterior aspect of the tibia?
There is a fracture.
Osteophyte, sir. Anterior osteophyte.
Anterior osteophyte.
Yes, it's what we usually call it as a spur-like growth on the anterior. It could be a fracture, an old fracture, or an osteophyte-like growth. So patient presented with pain. So this is the X-ray. So what is your diagnosis?
Anterior angle impingement, sir.
Yes, just like the posterior impingement syndrome due to trigonum that we discussed. So this is called the anterior impingement syndrome due to the spur formation or an old fracture of the anterior talus of the tibia. The osteophytes coming or an old malunited fracture due to the avulsion of the ligaments. So these are the reasons for this spur formation on the anterior aspect. And patient present with pain, especially on dorsiflexion during walking and all. In posterior impingement, you get pain on plantar flexion on the posterior aspect and tenderness on the posterior aspect. And here, pain on dorsiflexion and tenderness on the anterior aspect. That is the difference. And coming to the treatment, most of the time it is conservative treatment only, like NSAIDs and rest, and then you can try steroid injection and physiotherapy. And if the conservative treatment fails, you can go for arthroscopic excision and excision of this fragment along with the fibrotic tissue in the vicinity of the anterior aspect. So this is the anterior impingement syndrome. Okay, with this we will wind up the session. So any questions? So you all should know the, especially the ankle fractures with the classification of the ankle fractures and talus, the classification of talar fractures and the complications of talus. So ankle joint is concerned with the lower fibula, tibia, and the talus. So the pathology concerned with that area, especially the fractures and other the chronic conditions. You should be able to answer these questions. So that was the idea of this OSCE. Hope this was useful to you. And if there is any query, you can ask or you can post in the next OSCE session also.
Thank you,
Babu,
sir.
Thank you, sir.
Thank you, sir.
Wonderful selection of cases, sir, especially the angle fractures, which is very commonly we deal with, as well as it's a very common OSCE question.
Yes.
Thank you for including all this. Very important questions, sir. Jis, sir?
Thank you, Dr. Murugan. It's a wonderful session. Thanks.
Is this there? Okay, so I was teaching person only once in a while only I come for this clinical discussions. So hope I have covered a bit of angle pathology.
Yeah, definitely. Well covered. You focused on, at least they have learned something about the syndesmotic injury and how to do a proper log function. That's really great. Thank you very much.
Thank you for giving the opportunity.
Thank you, Jis. Babu sir, Balu. Okay. And all the PGs. Okay.
Last
Bye.
comment, very.
Right. Thank you. Thank you, sir.
Thank you, sir.